Hi, I'm Alyssa Weiss, and I'm presenting with Sally Weiss. She is my mother, so it does come around where you do present with your mother when you never thought you would. We are doing it on postnatal depression and interprofessional approach across cultures. Senior Dr. Weiss is in the medical field. She is an ARNP, and she worked in a nursing school. She also is a professor right now in online nursing school. She was the associate dean and dean of a nursing school. So we're looking at different aspects. I am in the mental health field. I have a private practice and I work with families and individuals. And I've been coming, a lot of new moms have been coming to see me. So I've been doing a lot on postnatal depression. So I will now give it to the senior doctor.
Good morning or afternoon, depending on what time zone you're in. Can you get me my next slide? One of the things that we looked at was how this particular disorder, postnatal depression, and some of you may be more familiar with the term postpartum depression, it affects others outside of our unique Western culture. And one of the things that we need to look at is with the diversity and the diminishing of our global barriers, we really need to look at how providers in a variety of fields work with patients or clients who present with different types of mental health disorders. And the other thing that we need to look at is culture is becoming a great influencer on how our patients and clients present to us, as well as how we present ourselves back to them. There's various sections of the world that are becoming increasingly multicultural, and providers from all disciplines have really been encouraged to develop their skill set in dealing with cultural humility and cultural diversity. And one of the things we discovered is we were really looking at this, and Dr. Weiss has the counseling experience with patients with postnatal depression, is that culture concerns are global and that there is a higher number of individuals who present with this disorder than we originally thought. Okay. So there's several studies that have demonstrated that cultural factors play a significant part in the development of postpartum depression or postnatal depression. And these factors seem to influence and even precipitate the onset. And these factors also contribute to how we can intervene in multiple disciplines. And that's one of the things that we need to look at. This is not unique to one particular profession. It's a treatable illness. Although it's often looked at in a medical perspective, it encompasses a more holistic approach and viewpoint. It can develop anytime from a few weeks to a year after a woman gives birth. It's often difficult to identify because the symptoms are very similar initially to what we always refer to as the baby blues, which are very short in their duration and do not encompass the multitude of symptoms that we find with postnatal depression. What sets postnatal or postpartum depression apart is how long it lasts and also the severity of its symptoms. It can begin 1 to 2 months after, and there's very strong feelings of depression or thoughts of despair or hurting oneself or the baby. Literature has shown us there's a very high incidence of the disorder, and it's higher than we originally thought, with a wide variations of presentations depending on the early recognition and diagnosis and how countries and cultures identify and treat this. And what makes it important is that these are only the cases we know about. There are many we have no idea about because they're not reported or they're not recognized. The WHO, World Health Organization, which I know you're all familiar with now with what's been going on, says about 10% of pregnant women and 13% of women who have just given birth experience a mental disorder of some kind, and postnatal depression. In developing countries, we find it can be even higher, but we're not sure because of how they identify and treat. And it's been reported globally anywhere between 0.5% to 60%. Interestingly enough, and I think that you heard in one of the earlier presentations about the Asian countries, there's a difference in each Asian country on recognition and how they actually report postnatal depression. And that's a really important thing to think about. A variety of us are exposed to different cultures depending on where we live geographically. We have a very high Middle Eastern population here in the South Florida region. And we also have a high Hispanic population in this region. And they often present very differently, using more somatic approaches. But one of the things that we really need to think about is the history of this disorder. It's not new. It's been around for centuries. And historical accountings of these symptoms following childbirth can actually be found in the literature as early as Hippocrates, who first referenced this in the 4th century. In the 13th century, we had a female physician, highly unusual at the time, who documented another reference to postnatal mental symptoms. And interestingly enough, her definition is if the womb is too moist and the brain is filled with water, that the moisture runs over in the eyes and compels them to involuntarily shed tears. Well, when we think about our modern theories, which we'll talk about in a few minutes, it has a great deal to do with an imbalance in the brain. And during the Middle Ages, women who showed signs of depression, or what they called at the time was melancholy, were thought to be under the spell of witches or witches themselves. And this was not uncommon during the Middle Ages at all. Branco, who's a 16th century physician, was actually one of the first physicians who looked at this from a modern type of viewpoint that we would look at. He found a case where he tended to a very wealthy woman who he described as remaining insane for a long period of time, but she recovered with treatment. Although he doesn't prescribe the treatment in detail, this was the very beginning where experimental treatments were used to deal with this disorder. So the first thing we see is that it's really recognized as something that is associated with childbirth, and B, that they're actually thinking of ways to treat it rather than thinking that the woman is just hysterical and locking her away, which also used to happen a great deal as well. The French psychiatrist Esquirol was the first who really provided us with any detailed cases. He treated 92 cases, but again, he thought the numbers were higher, something that again aligns with what we're thinking of. At the time, he felt that good nursing care, tepid baths, and purgatives, which were used for just about anything at the time, helped. But if we look back at tepid baths and nursing care, these were interventions that actually helped in relaxation and in reflection. He was also the first to divide anything into a time frame, so that he looked at it under the auspices of the stages of postpartum, which was initial, the puerperal time, lactational, which occurred several weeks after delivery when mothers started feeding their babies. And these categories were used for decades. And then we have MacDonald, who was an American psychiatrist who felt the classification should be based on symptoms. And he used opium at the time, which again was used for a great many ailments. And as we know, opium is the basis for many of our narcotics, and it has a relaxing effect. Bringing us up today, we have to look at the 20th century, where we actually had a little bit more focus on the disorder itself. And depression after the childbirth for one theory, was it wasn't related to the pregnancy, it wasn't associated with postpartum changes, and was from other psychiatric illnesses. One of the things we know today in the 21st century is that individuals who do have other signs of depression or other mental challenges often do become more susceptible to postnatal depression. However, the study still argued that this is a psychiatric illness. However, maybe we shouldn't look at it that way because they seem to think it was only associated with pregnancy. So they actually took it out of the DSM for a little while. It is presently back in. At the time, there was no thought given at all to any differences in culture or background, genetics, environmental factors. And these we have found today in the 21st century are actually quite important on how we look at this disorder, recognize it, and treat it. And notice I call it a disorder and not a disease, because it is associated with specific precipitating factors. So that takes us to today. In the 21st century, what are we looking at? How do we recognize it? How do we identify it? And how do we treat it? We have several theories today, the biological theories and the psychosocial theories. And in reality today, we know we can't separate these. It's a biopsychosocial approach. We have to look at the treatment of the disorder holistically. And I am sure that many of you in your practices are coming across women with postnatal depression. So are there anyone out there that is actually working with patients, clients, who've come to you with postnatal depression?
Can you see the chat? Let me.
Yeah, but it'd be easier if you kind of read it through and looked real quickly.
All right, then I have to. So.
Okay. Very quickly, not to confuse anybody with the medical, I just want to say the hormonal changes include what we call the hypothalamus pituitary axis, adrenal axis, and that's important in the stress response. The hypothalamus, which is part of the brain, kind of thinks it's under pressure here. It sends a message to the pituitary, which starts releasing all kinds of chemicals. And then the adrenal glands begin to release what we call epinephrine or norepinephrine, which are the catecholamines. And they are known to cause increased heart rates, increases in sweating, and symptoms that we see physically associated with anxiety. The neurotransmitters we call the 5-HTs have to do with serotonin. And the reason that's important is that's because that's how our drugs work. And it also appears that there's an internal abnormal reaction to some of the hormonal challenges, and that contributes to the postnatal depression. More specifically today, we're also looking at the psychosocial theories. And it's really important to realize that there's neurophysiological and neurochemical changes that occur under psychological stressors. The body doesn't recognize whether it's physically stressed or psychologically stressed. It reacts the exact same way. So we need to look at it from all angles. And it isn't just medical treatment and it isn't just psychotherapy, but a combination of both. And depression, as we well know, is related with psychosocial stressors. So how many of you, I realize we asked the question, and I just wanted to know, are treating individuals with postnatal depression and may have a question at this point?
I'll stop sharing so you can look. Valerie works with women after a stillbirth, worked with a woman.
This is a very complicated issue because the stillbirth, there's grieving. So there's grieving of the loss, as well as the changes in the hormones. And so we have to separate out here, how long is this lasting? So in this case, we really need to look at which is which. We expect depression after loss. However, we also need to look at the length of time that this depression lasts and the type of symptoms that the patient is presenting with. And I'm not a big proponent on medicating somebody right away. I really think that a lot of this can do with meeting with a therapist and letting the therapist figure out which part is related to the actual grief and loss, and which part may be related to the chemical differences.
Another question is there a difference between postnatal and postpartum?
No, it's just a different terminology that's being used today. We're looking at it more as postnatal rather than postpartum, because postnatal extends longer than the postpartum period by definition.
I'll go back to the presentation.
Thank you. Oh, Kimberly, you just asked about perinatal. Perinatal is the time period within the pregnancy. Antenatal is before, perinatal is within, and postnatal is after. And that's a good question, because patients who are depressed during the perinatal period have a very, very high incidence of postnatal depression. So this is something that has to be identified very, very quickly during their care with their either midwife or OB. That's really a good question to ask. All right, next slide. One of the things we want to look at is in countries that have been influenced by Western values, once the baby is born, most of the attention and care of the health provider focuses on the baby and not the mother. And so the mother tends to be neglected. And I want you to think about that perhaps in your own lives. Everybody comes in and says, oh, the baby's so cute. Oh, how wonderful you have a baby. Oh, the baby. And here's mom that's sort of out there and not getting any kind of support or attention. And women who are attempting to breastfeed often need a lot more attention from the women in their family and from their healthcare providers than they get. And if they're having problems with lactation, this can also add to the depression. And then we get into a vicious cycle. They want to nurse, they're depressed, they can't nurse. The ability that they can't nurse affects the depression, and then we've got to find a break somewhere. Other cultures, however, put much more emphasis on the new mother. Down here, the Haitian culture, for example, needs to collect the placenta. And the importance of the placenta is they make a soup to help the mother feel better. Now, we have discovered that the placenta is very rich in proteins and chemicals that help in the healing and in moving forward. And the mother gets a great deal of attention from the elder women in the community. So that's an important thing that we see. So their physical and emotional needs are met in other cultures, and protecting the mother so that she can be effective as a mother are much more important. What's also interesting is more educated mothers, regardless of their cultural background, tend to negate the cultural influences that have to do with the support that they get in those cultures. And when they do that, that often leads them isolated and out there because they've rejected what can be most helpful to them. Lori has a question.
I don't, which is the question?
She was asking, are women who give birth in the US hospitals allowed to ask for the placenta?
Down here, yes. I can speak for what we do in the South Florida region. We are very cognizant of the cultural variations that we have here, and we do recognize that need. And so, yes, we do, particularly in the Miami-Dade area where there are a great many Haitian women who deliver. So we do that. The other thing I wanted to add is midwives are more likely to recognize the cultural needs of women often, and female OBGYNs are much more attuned to that.
There's another question, says that mothers experiencing postnatal depression are grieving even if they did not experience a stillbirth.
In some cases they are, but it's not so much a grieving as it is a feeling of inadequacy. New mothers feel inadequate and frightened to begin with. But in postpartum or postnatal depression, what happens is the mothers fear that she is not going to be able to care for this baby. She doesn't know what to do. She feels that she's not worthy of being a mother. All of these feelings come into play. Now, a lot of this can go back to history of their own environment. And that's why I said earlier, one of the things we really need to look at and what therapists need to focus on is how some of those messages and tapes playing in the head contribute to what's going on now. How much self-confidence does this person have to begin with as they move forward into motherhood?
Well, and that's when therapists, sometimes as I come from work, I use a genogram. So I look for the patterns and relationships that the women have with the other women in the family, how birth was for other members, and that when I get referrals from the OBGYNs.
Okay, next slide. So one of the things we have, there are a great deal of postpartum rights or postnatal rights in different cultures. That has to do with the days of confinement, meaning how long the mother stays inside and can't go outside. Any kind of controlled activities and diets. The Hispanic population looks at foods as being either hot foods or cold foods, and during certain illnesses or certain times of a woman's life, she either needs a hot food or a cold food. There's practical and emotional support from family members. Mothers-in-law come in and help in teaching and taking on roles as the individual who manages the family while the mother recuperates. Female relatives and traditional birth attendants are often practiced in Asian communities. We're using more and more in our country the presence of a doula, who is a birth attendant that assists the mother during the birth process, along with the healthcare personnel. Cultural rituals also have their own pros and cons, meaning that often there can be two opposite outcomes. And when we say this, the effect of a cultural ritual can often promote or it can inhibit the changes in the mother as she progresses through that postnatal period. But one thing that we have found is that strong, emotional, positive support by family members is very helpful for mothers coming from all cultures. What I have right here is the recognition of the disorder for the healthcare provider, because once we recognize the disorder, we need to initiate treatment. And the earlier treatment is initiated, the better the recovery and the mental and emotional health of the mother, which then contributes to the positive effect on the baby. So the biological factors we look at are the history of any kind of maternal depression. And that means in the family, not just the mother. So Dr. Weiss referred to using a genogram, which is a very important piece there. Family history. Has anybody in the family ever suffered from depression of any kind? Because the higher risk of depressive episodes within a family, the higher the chances that somebody will have a postnatal depression. Is there any substance abuse? Whether there are any problems with pregnancy and delivery, and somebody had asked earlier about stillbirth. So this is where that comes in. Sometimes what happens is, in our field, is women come in with a birth plan. In other words, this is what's going to be. I'm going to deliver naturally. I'm going to have a doula. I'm going to have a midwife. I'm going to have this. I'm going to have that. And it doesn't work out. And they end up where the midwife has to step back. They have to call in the OB. They end up with a section. And this contributes to feelings of failure. And so this now adds to the possible consequences with a postnatal depression. The breastfeeding, which I already said, I want to breastfeed and I'm having difficulty, so I'm inadequate as a mother. And any other kind of medical illnesses or medications the patient may be on at the time. Thyroid problems can often contribute to this. Social factors, psychological factors, looking at attachment, and Dr. Weiss will deal with that. And then we look at the interpersonal precipitants, like the role transition, going from being just married and it's just the two of us, and now all of a sudden I have this thing and it cries and I don't know what to do for it, and I'm tired and I'm doing the best I can and it still cries. And so a lot of this adds to the fear of being inadequate. And therefore, from all of these things and putting it together, we can come up with the diagnosis of a postnatal depression. Go ahead. So what are the symptoms? Some of the things that I see when a patient comes is this continuous depressed or down mood. They're complaining of sleep problems, which so often gets just pushed aside because here we have a new baby. That baby's waking up every 3 hours. So sleep problems, well, maybe you're just tired or this. I see a lot of somatic complaints, and those somatic complaints are headaches, general aches and pains, GI disturbances, either constipation, diarrhea, waves of nausea, a lot of anxiety, and mood swings, which again get pushed off because, oh, you just had a baby, your hormones are off. So yeah, you feel like crying, then you're happy, then you're crying. But when you look at it as a bigger picture, it's telling us something else. So what we find are risk factors for depression are very similar across cultures. How cultures interpret this distress differs tremendously because some cultures say, well, we have to suffer in silence. And one of the things that was discussed earlier today was the Asian culture, okay? Also some of the Middle Eastern cultures. There's other cultures where you can't talk about open communication. Women's needs are less important. And then in other cultures we have where the women's needs are highly important and being a mother is just the best thing ever within that culture. Okay, Chinese, interestingly enough, are likely to experience and express depression more as bodily symptoms, and they describe it as they just have a lack of energy, okay? And that's a symptom that goes across the board. We already talked about the somatic complaints and the role of the provider, but one of the other things that the healthcare provider needs to look at before jumping on this is physical reasons. For example, is mom anemic? She may be. That can add to depression and sleep problems, also add to appetite problems. We want to look for any chemical imbalances that may occur. So that could be with what we refer to as electrolytes, which are sodium levels and potassium levels. They can be off. And thyroid function is one of the biggest offenders that cause depression. Patients who come in after giving birth who may have low thyroid levels are depressed, tired, lack of appetite, and mood swings. So before we jump on the postnatal depression wagon, we always want to look at this. We want the patient to complete the Edinburgh postpartum depression scale. I'm a big proponent of non-pharmacological treatment before we jump on medications. Physicians are more likely to go on to medications. So as healthcare providers and as therapists, do you see a lot of patients coming in already medicated? Any questions on that? Nothing? All right, well, one of the things that I wanted to say,
There's
a question here. What does the research?
What does the research show about the postnatal depression being a precursor?
A precursor to?
For MDD, I thought you said.
For other, can you read that to me?
Precursor for MDD.
Major depressive disorder.
I didn't hear the last part.
What does research show about postnatal depression being a precursor for major depressive disorder?
There is, okay. However, that's a great question, Andy, because one of the things that we have found is that if that postnatal depression is not addressed early on, the patient can develop a major depressive disorder. The second thing is, has this patient had a history of depression prior to the pregnancy, and have they been on medication prior to getting pregnant? This too is a precipitating factor. So that's a great question. And there is a lot of research that's leading to that, which is changing some of the ways they're looking at medication treatment. And there's some newer medications coming out that are looking at.
Well, that question actually came from Teresa Reinhardt, I believe. But I actually do have a question about medication. We're seeing that that traumatic birthing experiences can cause traumatic symptomology, and there's also some research out there that shows now that getting a beta blocker within the first 24 to 48 hours of a trauma can reduce the trauma symptomology. And I'm wondering if if it would be contraindicated to administer a beta blocker to someone within 24 or 48 hours after giving birth.
The only contraindication that's a good possibility at that point in time would be the physical aspects of cardiac and blood pressure, and if the mother is breastfeeding.
Okay, well, then we should do that research then.
Yes, absolutely. Would be excellent research to do. And I don't think there's a lot out there on that, on using beta blockers postpartum. We do use beta blockers on patients postpartum who have been on beta blockers the whole time because they have cardiac issues. And we also use some of them for patients that have what we call pregnancy-induced hypertension during the pregnancy. So, but these are monitored very carefully, and not only with the high-risk OB, but also with cardiology.
Thank you, Dr. Older-Weiss.
Dr. Older-Weiss, thank you. Dr. Brown. This isn't something an FNP would do. This is very highly specialized when you get into that. The other thing that the provider would do is, when we're looking at pharmacology, one of the things, remember I said about 5-HTs and the serotonin, this is where the pharmacology comes in. The medications that we use that we call the SSRIs, or the serotonin reuptake inhibitors, they work on the 5-HT. And that's what helps the patient in decreasing the depressive symptoms. When I have seen patients, or some of my colleagues have seen patients, we look at it immediately as referring to the mental health provider. If the mental health provider tells us that they often feel that some medication may be warranted, then we look at some of the SSRIs, which are, there's several of them, but the one we like the best actually is Zoloft. It's got a long history of being effective. We know what the side effects are. We have a good idea of how individuals will respond to it. So it's one of our older ones, but it's effective. And so the other thing that we have to think about as healthcare providers from my end is our prescribing depends on our level of education and what our licensing and board rules are. Family nurse practitioner can describe an antidepressant for 2 months, but after that, they have to be referred to psychiatric mental health nurse practitioner or psychiatrist for follow-up with medication. The rules of the board where I am, and in many states, feel that if a patient needs long-term psychotherapeutic drugs, then they need to be monitored by someone who specializes in that field. So any questions for me? Any more? Angelique?
I had other questions earlier. One of them was, it seems the numbers have not changed much from the 1980s when I first started as a nurse. What are we not doing as providers to help ameliorate the situation? That's one question. The second is it standard practice to ask about family history of depression during, a prenatal visit?
It should be.
Okay.
I'm not a midwife, but I can tell you when I did my clinicals for my nurse practitioner, I did my clinical for maternal child with a midwife, and that was one of the first questions she asked of her patients.
Okay.
But she especially asked it if this was a second or third pregnancy. Were there any difficulties that she should know about if she didn't know the patient prior to, if this was her first encounter? One of the things that OBGYNs are talking about is that as part of the prenatal visit that they should be doing a scale.
Okay, excellent.
Yeah,
And
I think that we're not seeing the numbers because it's not being reported. It's not something that is reportable like to CDC, like a communicable or infectious disease. So we really have to kind of rely on differences that come in by research. And I think that's part of the problem. I am sure that it's much higher.
Yeah, I don't think that's good enough, actually.
No. I think we have to do more screening.
Yeah. Thank you.
You're welcome. Any other questions for me?
Dr. Weiss, in some cases, when you have a client that is taking multiple medications, can't the medications cancel out each other in many instances?
Good question. Hopefully, one of the things that's a rule of thumb is you never give two medications from the same classification. In other words, you would never give a patient Zoloft and Prozac. Okay? You don't normally give SSRIs with what we call the tricyclics. Okay, that's like Elavil. You wouldn't use Elavil and Zoloft together. So that's why when you start to get into some of these medications, they need someone who specializes in which medications can be used and not used together.
Okay, thank you.
You're welcome. Anything else for me?
I typed a question on here about breastfeeding.
Okay.
And how I had a personal experience that when I would initially pump, that I would feel this extreme sadness. Like it was like almost feeling like an extreme homesickness. That's how I kind of related it. And I looked that up because no one had ever told me that that was something. And then feeling the pressure to breastfeed from family and from these lactation consultants and just not feeling like adequate enough as a new mom. All that stuff really did exacerbate a lot of issues when I gave birth initially, like 2 years ago. And so I don't know if that's something that people have heard of, is like when you're breastfeeding initially, that reflex of the milk coming out causes some sort of sadness.
It can. There's hormones that are related to lactation. Oxytocin is one of them, okay? And that's one of the hormones that comes from the pituitary gland that lets the milk come down. And often during that phase when you're pumping and the hormones are released, the emotions go along with it. One of the things that we have found out is once the lactation schedule is set and the mother becomes more adept at it, and the feeding of the baby, that there are calming hormones that relax the mother and give many more feelings of elation. If when the mother is breastfeeding, these constant feelings of depression occur, this is something that needs to be reported.
Okay.
Okay. Were you successful?
Well, I couldn't, she never latched on because I had issues when I went into labor and delivery and C-section and all that. So I was pumping for a good 6 weeks and I could never get her to latch on. And I don't know, I didn't like the sensation, I guess. And I think that there was so much pressure. I was getting phone calls from lactation consultants and trying to, you know, deal with the pain of the cesarean and just so many things that I think that really exacerbated the baby blues and maybe a little bit of depression. I mean, I don't know. But I was so successful, I guess you could say. I don't know.
I do want to tell you that women who end up having a cesarean when they didn't expect to have the cesarean, yes, have more issues with breastfeeding. You're not different. You're not unique. It's not something that, you know, had anything to do with you. The medications that you get, the whole change in the birth plan, like Dr. Brown made the comment about the traumatic birth type thing.
Yeah.
All impacts the ability to breastfeed. And I think that our lactation consultants need to be a little more educated in that arena as well. Breast is best. We always say that, but there are times when it just doesn't work, and that doesn't matter. Okay, as long as you are bonding with your baby, holding your baby, doing skin to skin, and this is important for therapists to remember because you may hear this from a mother. I can't breastfeed. Everybody's telling me I have to breastfeed and I can't breastfeed. It's okay. It's okay. Hold your baby, love your baby, talk to your baby, do skin to skin. Same effect.
Yes, thank you.
And that's where they come in, you know, to see us as mental health. I put this on with the life preserver because, I mean, right now, how many of us right now feel like we could catch a life preserver with everything that's going on? But that's how a lot of new moms feel, is that they need this preserver to help them. And they feel that they're out there all by themselves with no assistance. And when they come to us, I come from a strength-based approach. So I sit with them for a while and then I try to find, you know, their strengths, because at this point they're now they don't know where they are. They don't know what they're looking for, and they lose that idea of that they do have these strengths and these skills. The other doctor always talks about the symptoms commonly to any depression, the feeling sad. What's unique to postpartum depression is the quick mood swings, or the fear of hurting the baby, or menstrual irregularities, or gastrin disorders. So it's not, there's all different types of things they're feeling at that time. There's some treatments that have been used a lot, is the psychoeducation, group counseling, cognitive behavioral therapy, interpersonal therapy, and psychodynamic therapy. With psychoeducation, we invite all members of the family that are in the household. We want to teach the client and the family about the symptoms. What are they looking for? You know, when you have a new mother and a new father, you know, the husband might be saying, oh, she's moody, she's this, she can't, you know, she's not handling this, but there might be more to it. And then the mothers are always tired of listening to, oh, I'm tired, I'm moody, but she can't explain what she's feeling or what's going on. So you discuss the available treatment options, the potential outcomes, and there could be a relapse of prevention, and that you talk about that. The next approach is the group counseling, which that also helps increase the social support for networks for women, that they don't feel that they're alone. A lot of group counseling is combined with the psychoeducation by giving them the literature, the wellness. The goal is to help support them, help build community support so they don't feel that they're alone and that their struggles they talk about, and they share their ideas and they hear from others. The next approach is cognitive behavioral therapy, which is time-limited treatment. It lasts about 12 to 14 weeks. It emphasizes the role of the thinking, how the person feels and behaves. And it identifies the distorted negative thinking pattern. So it emphasizes the links between the thoughts, the feelings, and the behavior. It helps them identify their distorted negative feelings. So by changing the way they see maybe the baby, they see themselves, that helps them to look at a different way of working through this. The next one is the interpersonal therapy, which is another time limited, and it focuses on your interpersonal relationships, the role transitions. It addresses the relationship between one's mood and one's social context within the 4 problem areas: role transition, role dispute, grief, and interpersonal deficits. One of the other treatment is to focus on the infant and the partner, your relationship with you and the baby, your relationship with your partner. How, you know, many of us have to go back to work. So what is the transition back to work in your other roles? The next approach is the psychodynamic therapy, which looks into the early experience at play in forming your beliefs about yourself as an adult, identify those beliefs that are no longer helpful. When we look at the psychodynamic, we're also looking at, you know, the past experience of with you growing up, the attachment, what type of attachment did you have with your parents, or with your mother when you're going back to thinking of these things. That's when I talked about the genogram. I always develop a genogram with my patient clients and look at those relationships and how they connect with each other. Often in this type of therapy with the psychodynamic is the ha-ha moment that allows them to have this self-validation, to have the empathy and the freedom and self-judgment. Many mothers put a lot of stress and pressure on themselves to be perfect when they have their baby because, you know, as Dr. Weiss said it, you know, you have this birth plan, you have this creation, you know, when you get pregnant, you have created this whole dream life of how this is going to work out. And then the baby comes out and something changes, maybe hormones or what, there's that connection for whatever reason. So you want to develop that connection. And sometimes the client doesn't feel that connection. That's what you deal with, talk to them about, that it's okay, and you normalize. Another approach which I use a lot is solution focus, which is the strength based, which highlights the mother's strengths and skills. So I sit with them for a while to talk about the problem with a lot of solution focus that I'd like to move them forward. But sometimes you need to sit there with them and be there for them. And then I move them forward in thinking, you know, what are your strengths as a mother? Where do you see your future with as a mother? How do you see this baby bringing change into your life? And tying it back to the different cultures. With culture differences, as Dr. Weiss spoke earlier, some of them focus on the mother. So like in Eastern Asia, South Asia, Africa, and Eastern Europe and Middle East, these cultures are for the traditional practice aim on the mother. So a lot of them come in like mothers and mother-in-laws, and they take care of the baby, giving the mother some time to recoup. So the care provided is about 30 to 40 days that involves a period of social isolation, mandatory rest, and emotional and physical support for the new mother. So they're taking on the role of taking care of the baby. In US and Canada, Western Europe, Great Britain, and New Zealand, and Australia, the primary concern in postpartum care of a baby comes in seconds. So postnatal care practice is usually 24 to 48 hours. They are, you know, discharged from the hospital, and now they're going home where everything revolves around the baby. And when the woman leaves the hospital, she goes back into the whole role of coming home, now taking care of a mother. So it's added other aspects. And then she might get up to 16 weeks for maternity leave. So there's not that emotional support like in the other culture sometimes, which is missing out because they talk about when they're going to go back to work, how they're going to balance the stuff. So oftentimes women feel that they're forced to take responsibility. So the implementations in the theoretical implications. So here I have a case study that here is Mrs. S. She's a 30-year-old woman, was referred to you by her OB/GYN for postpartum depression or postnatal following the birth of her first child. She had no prior psychiatric treatment, but history revealed a probable long-standing anxiety disorder with some avoidant traits. Her symptoms began toward the end of pregnancy and worse after the birth of her son. She said thoughts of running away and leaving her husband and her newborn son behind forever. She and her husband just moved to this area, and she does not have friends or family close by. She was not close to her mother, who had a drug problem, and her father died when she was young. Miss S does not get along with her mother-in-law either. So this was her first child, and Miss S had little idea on how to care for him. She had read different books and attended different parenting classes, only to realize they all said something different. She's now walking into your room for your first appointment. How do you begin the session? And I'm going to stop sharing so I can see the questions. Or you can just comment out loud. I know we only have a couple minutes. If anybody wants to share how they would approach Miss S. Elizabeth says isolation, I would say, is the largest factor here. Start with strengths, right? Seeing, you know, build up her community. So what would be some of the things that you would start with her strengths? Like, would you ask, you know, what types of questions could you ask? Tell me you've been successful in stressful situations in the past, right? Which is very solution focused. Like you know, asking, you know, when even going back with the anxiety, you know, when you've been anxious before, what are the things that you have done? Is the anxiety playing a role in? Yep, looking for support system. What does she like to do? You know, even bringing up about the husband. How does her, you know, her husband or partner play a role in helping with the baby? Ways that you've coped in the past. Mm-hmm. What has been your child rearing experience in the past? Would you bring up, knowing that she doesn't really have a relationship with her mother, would you talk about the what it was like for her growing up with her mom? When did the relationship, you know, not become well? Yes. A question might be something with the mom is like, what did you see that your mom did do well with you that you liked? You could use the Edinburgh scale. What are the positive aspects of your childhood? Yeah, bringing up past may elevate trauma, that's true. And that would be something you deal with, and that might have something to do also with the trauma as well of where she is today with the baby. I know we have a couple minutes. I don't know if the other Dr. Weiss wants to sum up some things and then have questions.
I can sum up.
I didn't hear you. You're going to sum up?
Yeah.
Okay.
Here you go. Go back. So one of the things that I wanted to say basically about postnatal depression is that this cartoon really expresses it well. When we see how helpless mom feels and then the support system comes in and now she's feeling better. And this is one of the biggest issues that we have. Our moms need support. They need positive reinforcement. They need to know that they are doing a good job. And that's really where the psychotherapist picks up. Just as Dr. Weiss said earlier, it is very important to focus on the strengths. How did you cope before? And moving forward. And as I said, medications are available, but if we can go forward without them, it's really the best thing to do. So thank you very much. I really appreciate your time today. And I hope that we were able to share something with you.
Thank you. I don't know if there's any more questions before we leave. I think we're good. Thank you for coming.